The next speaker is Professor Jeremy Krebs. And Jeremy, thank you very much for being here. Jeremy has been involved in EDOR since the earliest time. Jeremy, I think as many, if not all of you know, is a professor of medicine at the University of Otago, Wellington. He is also an endocrinologist and in fact clinical leader of endocrinology with Capital and Coast District Health Board, if it's whatever it's called now, Te Whatu Ora, and has been really involved in diabetes research with a particular interest in obesity, prediabetes, and has done a huge amount of work in that area. And I think you're mainly going to talk about prediabetes today, Jeremy. Thank you for being here.
Kia ora, Jim. Just a minor correction, I'm no longer the clinical director.
Well, compared to the management, we're not keeping up to date.
And perhaps if I could just take the opportunity to thank Jim. Seeing the photograph you put up there earlier was rather disturbing. 20 years does difficult things. But Jim's been a wonderful mentor and supporter of my career, and I thank you very much for it. And coming back 20 years ago from the UK and being embraced into EDOR and the community of researchers here has been wonderful. So thank you, Jim. Cherie gave me the topic of the conundrum of detecting prediabetes in New Zealand, and I've taken the liberty of broadening that out somewhat, because when I thought about it, actually there's a few more conundrums involved in prediabetes than just simply detecting it. If you think what is prediabetes, and you go to the great oracle of Wikipedia, what you are told is that it's an elevated glucose but below the threshold for diagnosis of diabetes. What the hell does that mean? It's also associated with obesity, dyslipidemia and hypertension, and is associated with an increased risk of cardiovascular disease. So this raises a number of immediate conundrums to think about. The first two are, what test do we use to diagnose prediabetes? And the second thing being, once you've decided what test you might use, what threshold might you take for making a diagnosis of prediabetes? Because of many as you in this room will be aware and know, glucose in the population is a biological continuum, and we make rather arbitrary cut-off points to make a diagnosis of these things. So how does that look? So there are a number of diagnostic criteria that have been proposed and changed regularly over the last few decades. And so I've got up there the current ADA, American Diabetes Association diagnostic threshold or cut-offs. We've got the New Zealand definition on the right-hand side, and we're simple beasts in New Zealand. We like whole numbers, so we don't like having numbers that are too difficult to remember, so that's why we have slightly different criteria to the rest of the world. And then we have an international definition, or WHO definition. And as you can see, there are three different ways that we can potentially diagnose diabetes. One is with an HbA1c, but more traditionally we've used a glucose-based test, and that has been either with, I'm going to use this wonderful, fancy, this is great, fasting glucose test, or more traditionally an oral glucose tolerance test. I don't know if anyone in the room has had the misfortune of having to do an oral glucose tolerance test, but it's not much fun. Firstly, you have to turn up to the laboratory fasting, then you have to consume the most revolting sugary drink that you've ever had and wait 2 hours without trying to vomit it up and have another blood test done. And people aren't very good at doing that, not surprisingly. So the reliability of these tests is quite tricky. But anyway, we have these three different criteria. And as you see, HbA1c here, the Americans like to diagnose a heck of a lot more people with prediabetes than the rest of the world with much lower thresholds. So what does this all mean? I've chosen to use the slide purely because I like the diagram. So it's taken from a study from a German population. But this is a conundrum that I pose to the medical students when talking about this. If you take 100 people walking down the street and you do an HbA1c and you do an oral glucose tolerance test, and 10 of those people have prediabetes defined with each of these criteria, are those 10 people the same 10 people? And what this slide shows is that's probably not the case. So you've got overlap between the different diagnostic criteria, but essentially you're defining different physiology by the different tests we're using. And that confounds and complicates all the research and all of the considerations about what we might do about prediabetes when we try to make decisions about policy and where we might go. So I come back to the next conundrum, is how common is prediabetes in New Zealand, with all of the caveats that I've just talked about how we might define it and which criteria we might use. And so I'm putting this paper up rather nervously because, of course, 3 of the authors are in the audience and could speak more to it than I can. But this has been a very highly cited paper and gives us an idea that actually prediabetes is pretty jolly common. And this was taken from the nutrition survey from 2008 to 2009 data, using HbA1c and at that time the ADA criteria. And across the population that was studied, the overall prevalence was 25%, a quarter of the population having prediabetes. And I didn't dwell on the slide initially, but showing the iceberg there, we think about diabetes as the bit of the iceberg above the water, but this shows us that actually the majority of the iceberg is sitting well below the water. And of course, there's some subtleties about that distribution of prediabetes in terms of obesity, in terms of ethnicity in the population. Now, that data is fairly old now, 2008, 2009. Do we have any more up-to-date data in New Zealand? So this is some data that was shared to me by Wellington Chan, a public health physician in Counties Manukau in Auckland. And what he's done is to use the TestSafe, which is a repository of laboratory data in the wider Greater Auckland area. And he formed a closed cohort study by taking data up to 2017 as entry into the cohort, and then the data from that in those individuals that were locked off at that entry point to that cohort. And coming back to the conundrum of which test we use and what difference that makes to the prevalence of prediabetes in New Zealand, you can see here the total population studied there was about 1.2 million. And if you look at the prevalence, if we define it by the ADA criteria compared to the international definition and New Zealand definition, then, oops, that's what I was trying to do. By the ADA criteria, the prevalence of diabetes in the population was around 6.4%, same for the international criteria, and slightly lower for the New Zealand criteria because, of course, our threshold is a slightly higher HbA1c. But look at the difference when you look at the pre-diabetes population. If you use the ADA criteria, then 27% of the population have prediabetes, compared to only 13% if you use international criteria, or 17% for New Zealand. So that's a massive difference when you're thinking about what you might do to intervene for this group of people. So the next conundrum then is, well, if we're going to define prediabetes, if we're going to call it a thing, a disease, why should we be worried about it? Because if it's not, we don't have to be worried about it, we shouldn't actually be bothered trying to define it. So conundrum 4 is, what is the rate of progression of prediabetes to type 2 diabetes? And thinking about that in terms of the criteria that we might use, thinking about that in terms of our population here in New Zealand, who is at greatest risk of progressing to type 2 diabetes? Therefore, who might we target potentially for an intervention? And then the other conundrum, as we saw from the first slide, because this is associated with cardiovascular disease, is who is at actually increased risk of developing cardiovascular disease? Is it the same people who are at risk of progressing to diabetes? So this is just an example, again, I've chosen this study just to make the point that if we use different criteria to define prediabetes and then look at who progresses on to developing type 2 diabetes, what difference does that make in terms of the hazard ratio? And you can see there, without dwelling on that again, there's quite a significant difference in terms of your predictability or your predictive value of defining pre-diabetes in that population. What do we know about that in a New Zealand context? Well, I come back to WINGS data from Auckland, and you've seen the top part of the slides there, but if we look at this closed cohort study and look at who then progressed on to developing type 2 diabetes over a 3-year period, what was the rate? Well, if we define it by the ADA criteria, then only 3.6% of the population, of that population progressed. So it was 11,000 people. If you use the international criteria, you get a much greater hit rate, if you like, of those who progress, and using the New Zealand definition, somewhere in between. Now you can see that the numbers actually, let's go back, the numbers are slightly less, so we potentially are missing people who are progressing on to type 2 diabetes using the New Zealand definition, but of course we're able to identify a greater proportion of those who are at risk and therefore may benefit from an intervention. Oh, crikey, time's up. Oh, my God. I better progress very quickly. I'm going to just make a few important points because I think this is really important to the discussion moving forward for us in New Zealand about choosing our criteria. And that is, if you look at this population broken down by their HbA1c at the beginning of that 3-year period and the percentage of people who progress, in fact, until you have an HbA1c of about 45, your chance of progressing to diabetes in that 3-year period is extremely low. So we're identifying a huge number of people and giving them a disease label who actually have a very low risk of progressing on to developing diabetes. And that then identifies questions of how and who we should target. This study was conducted by Andrea Teng and looked at another population in the northern part of New Zealand. Again, similar concept to see who might progress on to diabetes. And forgive me, I'm just going to make a couple of important points, if I may.
Yeah, please carry on, Jeremy.
Thank you. So once again, we can see here the graded and actually quite exponential differential between who progresses to diabetes depending on their entry HbA1c. And that also applies to BMI. The other important point about this slide is that men throughout all the range of this are far more likely to progress on to diabetes than women. And the other, I think, critical point when we're thinking about population health is that those who have prediabetes at a younger age group are also much more likely to progress on to diabetes than those at an older age group. And we know from other work that people who are diagnosed with type 2 diabetes at a young age do poorly. They have much worse outcomes in terms of complications. And the other interesting and as yet unexplained observation from the study is that one of the protective factors for those who might progress on to developing diabetes in this population, which had a large proportion of Māori, was that if you were fluent in Te Reo, actually your risk of progressing to diabetes was lower. It was a protective factor. I'm going to skip over this slide in the interest of time, but this was an analysis that one of my colleagues did from some data in people with prediabetes to look at those who had features of the metabolic syndrome in prediabetes and found that actually it was very high, but importantly, as opposed to the data I've shown you in terms of who is at risk of progressing to diabetes, where the threshold seems to be that HbA1c of 45, in fact here, people with an HbA1c in the lower range of prediabetes were equally at high cardiovascular or greater cardiovascular risk. So there's a differential there between the two conditions. So I'll finish with just some conundrums, which is going to be a nice segue into Mike's talk, was if we've defined prediabetes and we know who are more likely to progress, what do we do about it? What can we actually do about it? And this is where we think about the interventions that are available in terms of lifestyle management, weight loss particularly, and whether we should be thinking about medication. And then finally, should we be treating everybody with prediabetes at an individual level, or actually should we be looking at a more population health basis? And I think you can make that argument when we talk about that cut-off of an HbA1c of 45. I'm going to skip over that too. So just to finish, solving the conundrums, what do I think, my personal views on how we solve these conundrums that I've put forward? So which test and what cut-off? I think we've moved on from using glucose-based tests, rightly or wrongly. I think HbA1c is much more readily available and easier to do. So I think we're stuck with that. We need to make some decisions about what cut-offs we use, and I think I've given you an argument that probably the ADA criteria diagnose too many people with prediabetes, and that probably we should be moving to the international criteria in New Zealand. How common is it? Well, it is in that order of 17 to 20%. What's the rate of progression? Around about that 6.8%, but clearly important differences in our population groups, which will help guide us in terms of our targeting of interventions. And that being for males, younger, obese, Māori and Pacific, and perhaps teaching everybody in New Zealand to speak te reo might help. And what do we do about it? Well, I'm going to leave it there and hand over to Mike.